where the experts meet. Online learning, practical and sweet. Every Saturday, 9 a.m. Central Time. YouTube, Facebook, X, and LinkedIn. Online.
Hey, welcome to UroNurse. I'm your host, Vic Senese. Glad to have everybody on board. If you're joining us for the first time, or even if you've joined us before, don't forget, like and subscribe. We always like to have our likers and our subscribers. Hey, I'm going to bring my co-host in today. Lori, how are you doing today?
Good morning, everyone. I'm doing well. Nice warm weather today.
Yeah, it's neat how the weather's changed all of a sudden, and I think we finally stand a chance at having some summertime. So enjoy it while it's here, because the weather changes like overnight. All right, I'm going to be talking today, and I'm going to be talking about kidney stones. Kidney stones can strike without warning, and the pain can be intense. Anybody who's ever had one knows that. In today's episode, I'm going to break it down. Everything healthcare professionals need to know about kidney stones, including common causes, classic symptoms, diagnostic testing, and the latest treatment options. So join me right now, and today I'm diving into one of the most common and painful urologic conditions us healthcare professionals encounter: kidney stones. In this episode, Kidney Stones Explain Causes, Symptoms, and Treatment Options, I'm going to break down the science behind stone formation, review risk factors, recognize key clinical symptoms, and discuss current medical and surgical treatment options. From emergency department presentations to long-term prevention strategies, this program is designed to help nurses and healthcare workers improve patient education, symptom recognition, and evidence-based care. So, kidney stones, they form when certain substances in the urine, such as calcium, oxalate, uric acid, or cystine, become highly concentrated and begin to crystallize. Normally, urine contains chemicals that prevent crystals from sticking together. But when there's not enough fluid intake, or when there's an imbalance in these substances, tiny crystals can form and gradually grow into big stones. Over time, these stones can range in size from a grain of sand to larger stones that may block the flow of urine, causing significant pain as they move through the kidney and urinary tract. Now we can see in this picture that we've got the calcium oxalate and phosphate stones up on the upper corner. Next to that, to the right of that, is struvite, bottom uric acid, and cystine stones. So that kind of gives you an idea what they look like. Now, not all stones are the same. Most are calcium-based, but uric acid stones are common with those with metabolic syndrome or high-protein diets. Knowing the composition is vital because it determines how we prevent the next one. Now, if you ever wondered how stones form, maybe you did the same experiment I did when I was a kid with making rock candy. So what you do is you create a supersaturated solution by heating up water and sugar, as we see over there in step number 1. Step number 2, you need a nidus for the stone to attach to, so a string works for that. And you go and you put this highly concentrated solution into a thing to let it cool, a bottle like you see there, and the string in there for it to grab onto. And you can see from the last picture, you got a yummy rock candy piece of candy. That's a crystal. That's how crystals form. They need a super concentrated solution and a nidus to start building on. Kidney stone topology refers to identifying the specific type of stone a patient forms. And we can see from this chart here, calcium oxalate and phosphate, some of the causes: hyperparathyroid, high dietary oxalates, and high sodium or low citrate. And the fixes for those are there be underneath it. Uric acid, usually found with a low urine pH, like 5.5, an acid type urine. Things like high BMIs, gout, high purine diets can all lead to that. Fixes are there below. And cystine is the rarely genetically formed stone. It's a rare genetic mutation. You can see this run through family lines. If you don't have the genetic mutation, you won't have the problem. Fixes are even harder because there's not a real good single fix. It's a massive hydration, sodium protein restrictions, and some medications that we can use to bind those. Now, kidney stone formation is best understood as a balance between genetics and environment, where both play a role in determining how you're in determining your individual risk. So genetics can influence how your body handles minerals like calcium, oxalate, and uric acid, as well as how concentrated your urine tends to be, meaning some people are simply more biologically prone to forming stones. Environmental factors such as low fluid intake, high salt or animal protein diets, dehydration from heat or exercise, and certain medications can then tip that balance and trigger crystal formation. When these inherited tendencies and lifestyle factors overlap, urine becomes more concentrated and chemically imbalanced, creating the ideal conditions for stones to form and grow over time. Now, renal colic is the explanation or the name for the intense pain that occurs when a kidney stone moves from the kidney into the ureter. We can see from this picture here that stone is kind of stuck there in the ureter, and when it gets there, urine backs up behind it, as we see on the picture, and it's that backup causing stretching and to the kidney that causes that severe pain. So as the stone travels, it can partially or completely block the flow of urine, causing the ureter to stretch and spasm in an attempt to push the stone forward. This obstruction leads to increased pressure within the kidney and triggers strong pain signals through the surrounding nerves. And it's often felt in the flank or back and sometimes radiates to the lower abdomen or groin. The pain typically comes in waves because the ureter contracts intermittently, trying to dislodge the stone, which is why renal colic is often described as severe, cramping, and fluctuating in intensity. Now, if you've ever taken care of a patient with renal colic, you know how bad they are. I mean, they are just absolutely miserable. We send them right away to the emergency room. Don't even bother coming in to see us because it's just not going to be something we can handle. We don't carry narcotics and such in our office. But here's the 7 early warning signs, as you can see. Somebody's having mild persistent flank pain or dull ache, radiating pain down the groin, lower abdomen, inner thigh, sudden urinary urgency, frequency, or burning. Big key one, nausea and vomiting. That's always seen with this. Colicky restlessness, they can't get comfortable no matter what you do. And then sometimes you're going to see some blood, actually naked eye hematuria, and sometimes it'll be microscopic. Well, you'll see it on the dipstick. And they can have cloudy or foul-smelling urine. Now, the escalation care staircase for kidney stones describes how treatment is matched to stone size, location, and hardness to safely clear the obstruction. Small stones, typically less than 6 millimeters, are most often managed medically with hydration, pain control, and medical expulsive therapy to help the stone pass. For softer visible stones, visible on x-ray, in the kidney or ureter, we can do something called a shockwave lithotripsy, which can break the stone into smaller fragments that can pass more easily. When stones are trapped in the ureter or are harder and not responding to non-invasive methods, ureteroscopy with laser lithotripsy allows direct visualization and precise fragmentation and removal. For large stones greater than 2 centimeters or complex staghorn stones that fill parts of the kidneys, percutaneous nephrolithotomy is typically required, using a minimally invasive surgical approach through the back to remove the stone in larger pieces. So let's talk about medical expulsive therapy. That's when it's a treatment approach that helps the body pass a stone more easily by combining hydration, pain control, and a medicine to help relax the smooth muscle of the ureter. And for those of us who treat prostate, we know what that drug is. That's the alpha blocker class, our good old tamsulosin. It helps to reduce the spasm and decrease resistance in the urinary tract, allowing the stone to move more smoothly towards the bladder. By widening the urine and calming down those painful contractions, this therapy can improve the chances of spontaneous stone passage, especially for those 6 millimeter and less stones, while reducing discomfort and need for surgical interventions. So kind of rare that we operate on those small stones. Most of the time we can get rid of them unless the pain is so severe. Now, surgical interventions break down into the following: ESWL or extracorporeal shockwave lithotripsy. Again, that's the acoustic shockwaves that can break bigger stones into smaller stones that you can pass. Ureteroscopy, endoscopically going up there and blasting it away with a laser beam. And then for really big stones, the percutaneous nephrolithotripsy. Those are our staghorns or 2 centimeter stones, where you can put a pencil-sized device into the kidney itself and go and chip away at these things. So let's talk a little bit about ESWL to start with. So ESWL, or extracorporeal shockwave lithotripsy, is a non-invasive treatment for kidney stones that uses focused high-energy sound waves to break stones into smaller fragments that can be passed naturally through the urine. During the procedure, the patient lies on a treatment table while a machine targets the stone using imaging guidance, delivering shockwaves through the skin without any incisions. ESWL is the most effective for small to medium-sized stones that are soft and located within the kidney or upper ureter. The trick on ESWL is the stone has to be surrounded by fluid for ESWL to travel through, because it goes through fluid till it hits that stone and then causes it to break. So a stone that doesn't have a lot of fluid in the ureter is not going to break up as easily with shockwave as in the kidney where it's surrounded by urine. Now, along with the procedure, typically drinking plenty of fluids to help flush those fragments out, because you're going to still have the stone. It's just big chunks are turned into tiny little sand that passes, hopefully easily passes out. Sometimes we put stents in if there's a lot of stone burden to prevent that stone from blocking the ureter as it's coming down. So that can be used, but people don't really like stents, so we try to avoid it when all possible. And on shockwave lithotripsy, when I first started, it was a bathtub people had to get into. Big old bathtub, you'd get into this giant thing, and the shockwaves would go through the water, through the body, and hit the stone. They were aimed at the stone. And actually, they told me, go ahead and put your hand in the water and see how close you can get to where the patient's stone was, next to the patient. And as you started moving your hand through the water, you could just feel how hard those painful those things would be. So it required, of course, the anesthetic. Nowadays, we rarely use the tub bath, although some people think it still does a better job. But we have these water bags that are put up against the patient, and that's how we do it. Now, I talk about a new procedure coming out where there is a portable, like handheld device that can be used to break stones, and even being done in the office under less anesthetics. So we're just evolving this whole technology, folks. And a lot of offices do bring the machine into their office and do stones right in their office if they happen to have a surgery center. All right. Now, some of these harder stones, we can't just blast, or like I said, if there's not a lot of fluid when they're in the ureter surrounding them, it's difficult to do. So we use something called ureteroscopic with fiber optic laser dusting. We blow it away with a laser. And you can see that's a great picture of what's happening there. The ureteroscope goes up to the stone. We normally put a basket somewhere around there to kind of grab hold of it and remove some of the fragments, sometimes with the basket. But we hit it with a laser beam. It shocks it and causes it to crack up. So once that's done, it's pretty easy to get those little fragments out with, like I said, with something like a basket like you see there. Now, there's several types of medical lasers that are used in kidney stone treatment. Most common one is the holmium YAG, YAG laser, and the newer thallium fiber laser, or TFL. Holmium YAG laser has been the long-standing standard in ureteroscopy, effectively breaking stones of all compositions into fragments that can be removed or passed naturally. It delivers a high-energy pulse through a fiber directly into the stone. The thallium fiber is newer technology and uses a more focused, efficient energy delivery system, allowing for finer dusting of stones, faster fragmentation, and potentially improved precision with less stone migration. Both lasers are used through a ureteroscopy approach, and choice depends on stone size, location, composition, and surgeon's preference. Now, when the stone is really big, like we see in this picture here, like a staghorn calculus in the kidney, traditionally we used to have to open up the kidney, take the stone out physically, big operation. Not anymore. We can do this through little percutaneous nephrolithotripsy instruments. We just poke a pencil-sized instrument into the kidney, and then we can start, again, blasting away the stone. The procedure involves percutaneous access to the renal collecting system under fluoroscopy or ultrasound guidance, followed by a dilation of the tract to insert a nephroscope for direct stone visualization and fragmentation. Then we can use ultrasonic, pneumatic, or laser lithotripsy devices. Stone clearance is achieved through active extraction of the fragments, with the goal of achieving a high stone-free rate in a single session. Postoperative management typically involves nephrostomy tube placement or tubeless approaches depending on the intraoperative findings, with attention to hemorrhage risk, infection, and urinary extravasation. PCNL remains the gold standard for high stone burden due to its superior efficacy compared to less invasive modalities. Now, we got the stone out. That's the first part of the bargain. Most patients that have formed one stone go on to form another stone. So we need to do a metabolic evaluation. So metabolic evaluation for kidney stone formers is a structured chemistry mapping process designed to identify the underlying biochemical drivers of stone disease and guide targeted prevention. It typically includes serum studies like calcium, phosphorus, uric acid, electrolytes, bicarb, creatinine, and PTH, along with at least one or often two, we like to do two, 24-hour urine collections assessing volume, calcium, oxalate, citrate, uric acid, sodium, pH, and supersaturation profiles. This data is interpreted as an integrated risk matrix to determine whether the patient has hypercalciuria, hyperoxaluria, hypocitruria, hyperuricosuria, low urine volume, or pH abnormalities contributing to the crystallization. Remember that rock candy I was making. The goal is not just stone identification, but phenotype classification of stone disease, allowing clinicians to tailor dietary modifications, pharmacology therapy, and hydration targets to reduce recurrence and modify the patient's urinary milieu towards stone inhibition. Targeted pharmacologic prophylaxis for kidney stone disease is based on metabolic phenotypes identified through serum and 24-hour urine evaluations, aiming to correct specific biochemical abnormalities that drive this crystallization. So, now, take a patient with hypercalciuria. Thiazide diuretics reduce urinary calcium excretion by enhancing distal tubular reabsorption. For hypocitruria, or persistently acidic urine, potassium citrate is used to increase urinary citrate, a natural inhibitor of stone formation. Citrate keeps calcium and oxalate from binding, and it raises the urinary pH, particularly in uric acid and calcium stone formers. Hyperuricosuric patients may benefit from allopurinol to reduce uric acid production and downstream calcium oxalate supersaturation. Reminds me of that supercalifragilisticexpialidocious from Mary Poppins, oxalate supersaturation. Adjunctive strategies include dietary sodium restriction to potentiate thiazide efficacy, protein moderation, and maintaining high urine output. Therapy should be individualized, monitored with repeat metabolic panels, and adjusted based on follow-up urinary supersaturations, expialidocious, indices to ensure sustained reduction in recurrence risk. Long-term, we want to get the stone-free protocol loop going. True long-term freedom from nephrolithosis requires shifting clinical focus from episodic management of acute obstructions to sustained control of the underlying metabolic environment that drives stone formation. So prevent the stone from forming in the first place rather than treating the problem that happens when it forms. The stone-free protocol loop emphasizes a continuous cycle of evaluation, intervention, and reassessment. Acute stone clearance is followed by comprehensive metabolic workup, targeted dietary and pharmacologic modification, and longitudinal monitoring of urinary chemistry to confirm risk reduction. This approach reframes kidney stone disease as a chronic, relapsing metabolic disorder rather than an isolated surgical event, prioritizing prevention of supersaturation states that lead to nucleation and crystal aggregation. Did you just sing that Mary Poppins song? By closing the loop with the repeat 24-hour urine testing and therapy adjustment, clinicians can actively modulate the urinary milieu over time, reducing recurrence rates and moving towards durable stone-free status rather than repeating procedural interventions. So, in conclusion, the management of nephrolithosis must prioritize not only the resolution of acute obstruction and the relief of renal colic, deliberate transition of the patient to a sustained, pain-free, and stone-free state through comprehensive protocol-driven care. While acute intervention focuses on analgesia, decompression, and definitive stone clearance, True clinical success is achieved when this is integrated with metabolic evaluation, risk stratification, and targeted prevention strategies to interrupt recurrence pathways. For us healthcare workers, this means viewing renal colic as the presenting symptom of a broader chronic disease rather than an isolated event, and ensuring each patient is guided through the full continuum of care, from emergency pain control to definitive therapy and long-term metabolic optimization, thereby reducing recurrence, preserving renal function, and the best thing is a pain-free life. All right, with that, let's go on to any questions that you might have. Put them in the comments and we'll talk about it now. All right, so that was, I think, a pretty comprehensive review of kidney stones.
Yeah, great job.
Lori, any big comments you have or stories about kidney stone patients you'd like to share?
Well, I mean, patients who come in with kidney stones have that classic look. They're going to throw up and have an emesis basin ready, and they're just miserable. So I personally have had kidney stones. How about you, Vic?
Wow. No, thank God.
No?
You know, it runs in my family. My brothers had them. My dad had them. They both had uric acid stones, and they both suffered from gout. So I don't suffer from gout. So
that's
so
good.
far, so
right
good.
now, I'm pretty sure I'm kidney stone free. I had a CAT scan recently, and luckily, but I've had a few, and you know,
Yeah.
they keep telling me to stop drinking my Diet Coke, but I told them that I'd rather drink Diet Coke and have a kidney stone.
So you're the
But-
perfect one to ask this question, because they always say kidney stone pain is worse than labor pain, and I know you've had both. So
I've
go
had
ahead.
5 kids. So, you know, me personally, I think that the labor was actually worse in my opinion. But I mean, the pain was bad enough to go to the ER with the stone. But for me, it was actually labor.
Yeah. Wow. All right. Well, there you go. So no matter how you cut it, the stone pain isn't fun. And we often have patients that, you know, are kind of routine stone makers, and they'll call up and they'll say, I got to get into the office. I said, oh, no, you don't. You need to get to the emergency room, because
Yeah.
we don't have good drugs in our office to get you out of pain.
That's true. A lot of people, you know, will call and be like, I have to get in today because I'm having so much pain. Well, you just need to go to the ER because we can't do anything in the office,
Yep.
you know?
Yep.
So
Have you dealt with many patients with cystine stones? Now, those are the ones that are genetic.
very, very rare. Very rare.
Yeah. We had two secretaries that were twins that worked for us that both had cystine stones.
Oh, wow.
That is not why they started working for us. It just happened to be coincidental that they were cystine stone makers. But it was like they're almost routinely, you know, throwing a stone every now and then. And they're usually hard stones to break. They're big stones generally. So they're really a pain in the neck to deal with. And I know that the old drug we used to put them on was penicillinase. I don't know if that's still what's being used or not, but
Not familiar, really.
yeah,
But-
but it's you know, one of the things that for all stones that we try to tell patients to do is drink more. You need more fluids. Not
Yeah, that's
necessarily Diet
number
Coke,
one.
though.
I
you
am
and
not
Trump.
I'm not the one to talk about drinking water, I can tell you, because I definitely need to drink more water. But yeah, most of the stones are, you know, a lot of summertime people dehydrate and so forth. So yeah. Usually
And
that's
then there's
number one.
also something they call the stone belt, which is just a geographical area of the country that tends to have a higher stone risk. We happen to live in one of the stone belts too. I think it's just the combination of the hot weather we get, and as you say, you know, the summertime comes, you don't drink enough and you start dehydrating, and it's a sure way to, if you're a stone maker, you're going to make another one.
Yeah, absolutely.
So
I know that one of the things that you know, I often tell people about, you know, because a lot of people will have stent pain, you know, when they have a stent, but afterwards, when they have the stent removed, that's when pain can happen too. After the stent's removed, I always prepare patients that it may feel like they didn't get the stone out because they're having ureteral spasms, but yeah, I always do that because we get that call all the time after we remove stents that they're in all this pain and they think that they haven't taken care of the stone, but it actually has been taken care of. They're just having ureteral spasms, which can be just as bad as stone pain. So
I know one of the best drugs that came along for small stones, like 5 millimeter or less, was tamsulosin. I mean, we've had a lot of patients that use medical expulsive therapy using tamsulosin and some fluids and some.
Yeah, we have trained our ERs, even though they're not 100%, but we have trained our ERs on what to give people. You know, we're staying away from the narcotics. We're doing more of the ibuprofen. We're doing the tamsulosin. And it's really disheartening to see those patients come in who have small stones that they could pass, and they don't put them on an alpha blocker. Oops.
Yeah. Oh, Lori just this. There you are.
I'm here.
The cat did it, right?
Wrong button. Yeah, exactly. Yeah,
blame the cat.
I can't blame him right here.
So I know one of the things we always try to really drill home for patients is that fluid intake. If you can increase your fluids, and we had one doc in our office who always said that patients need to never pass up a faucet, and they need to drink enough so that their urine is almost clear. So if you're seeing, dark yellow urine, you're not drinking enough fluids. Make sure that you drink more, because that's key. But the other thing I found, I know maybe see what your take is on it. When you pass your first stone and you get through your first stone, you go right back to the same old habits. It takes at least 2 stone incidents to get religious. What do you think?
I'm still not religious, and I've had more than 2 stones. I guess, I don't know. Maybe I have to have the worst experience to but
you just won't give up that Diet Coke.
No.
I know.
No, sorry.
Yeah, well, that would be if I was, stuck and I couldn't get my coffee, then
everybody has to have their vice. So
you got to have your vice. I love my coffee in the morning, and I think I would deal with a stone, but thankfully so far, no stones. But I thought this was a great review to kind of hit stones again, because we haven't done it in a while. And heck, I haven't talked for the show in a while because I've had so many great speakers coming on that I kind of missed it. So I thought, hey, maybe I'll start doing a few talks. So hopefully you guys like it. Put it in the comments. If you don't, then I'll get more speakers. But I had a good time doing it myself. I always like to kind of look at the latest research, see what's coming up. It's always fun.
Absolutely.
So now I got another little promo I'm going to hit you guys with. 2 weeks from today, we're going to hit our 200th episode. I mean, this is episode 198, 200 episodes of UroNurse. And we're going to have a celebration. So Lori's going to be joining for the show. And I'm going to also have Dr. Jeff, who's the host of Dr. Jeff's Sex and Intimacy show, joining us for that show too. We're going to have all sorts of information about what's going on with the show, what's happened on the show, kind of fill you guys into where UroNurse is at, maybe some surprises even. So join us for that in a couple of weeks. And you looking forward to that one, huh, Lori? Can you believe it? You've been with it. I
can't even believe it's 200 episodes. That's insane.
200 episodes. Now, I've never missed one. Now, Lori's got to have surgery because she does crazy things.
Yeah, right.
But I mean, to stick with something for almost 4 years, and a few more weeks after that, I started celebrating the 1-year anniversary. Then I started thinking, well, these kind of come pretty quick. So I went to the hundreds. So last time we celebrated was on our 100th episode, and now we're hitting 200, and it's really been going strong.
It's been an amazing journey for sure.
It is. It's been a great journey. I tell you, I look so forward to Saturdays being on the air. So it's fun to kind of hang out. Now, next week,
stay ahead of the latest evidence-based practice with this essential update on the newest vasectomy guidelines from the American Urological Association. In this episode of UroNurse, host Vic Senese is joined by nursing expert Dr. Suzanne Kwolek. This discussion delivers practical insights you can apply immediately. Learn about updated recommendations on patient counseling, procedural techniques, post-vasectomy semen analysis, and how to improve patient outcomes. Join us on May 23rd at 9 a.m. Central Time to learn more.
Yeah, I'm looking forward to that. Suzanne Kwolek is going to join us. That's her expertise. And she was telling me recently, I was on a show with her for the Dr. Jeff show, and she was saying, hey, Vic, do you know that the AUA just released the new guidelines on vasectomy? I go, I didn't know that. She goes, yeah, you ought to do an episode on it. I said, no, you ought to do an episode on it. So she agreed to do the episode, and she's always great to have on. She's really got a lot of energy and great information. So we're looking forward to her talk next week. Hey, I saw all the thank yous coming and how great we did of a job on the show today from the comment zone. So thanks, folks. And a lot of people out there having fun today. And I think it's a great time to start getting out there and enjoying this weather. We finally broke winter's back. We're into the good stuff now. So, all right. Well, have a great day the rest of the day, Lori. And we'll see everybody next week on uronurse.com.
So here's to the moment.